next slide. Sorry, it's okay. It's okay. Here? Okay.
Philippines.
Uh, Again, okay. So next, my topic is ESD. Before my presentation, I have one question. So, have you ever performed ESD for human? Raise your hand. For human, only one, two, or three. So for pig, stomach, or hands-on? Oh, okay, okay. So I'm sorry, I don't know about the incidence of gastric cancer is very low here. However, gastric ESD will start at gastric ESD. So it's a very basic. So today I'd like to talk about ESD for early gastric cancer. Okay. Oh, oh. So let's try. So, so okay. Okay. So the agenda. So basic knowledge, basic technique, management of complications, approaches for difficult cases, and handling of ESD specimens. So many. So I talked a little bit earlier. So first, talk about basic knowledge such as ESD indication and curability assessment after ESD. So first, basic theory. So this is a flow of treatment for early gastric cancer. When EGC is diagnosed, you have to decide ESD or surgery according to ESD indication from endoscopic evaluation. After ESD, curability is evaluated by pathological results and decided whether additional surgery is necessary or not. Okay. So indication for endoscopic resection is not for which can be resected. So, but for which can be cured by endoscopic resection. Okay. So as you know, surgical resection included gastrectomy with surrounding lymph node dissection. But endoscopic resection is a local resection that removes only this region in the stomach, the region in the stomach. So without lymph node dissection. So therefore, endoscopic resection should be indicated only for region with extremely low possibility of lymph node metastasis. So endoscopic resection is considered for tumors which have a very low possibility of lymph node metastasis and suitable for en bloc resection. So when EMR by snare was the main method of endoscopic resection, so endoscopic resection was indicated as a standard treatment for differentiate type and without ulcerative finding, and clinical diagnosed as intramucosal, and the diameter is less than 2 centimeter. However, only 8% of early gastric cancer met the above conditions. Only 8%. So the ESD indication expansion is considered. So in the early 2000s, endoscopic submucosal dissection, ESD was developed mainly by Dr. Ono or our previous boss. By using ESD, it's possible to perform en bloc resection of region rather than 2 centimeter and the region with ulcer finding, and the expansion of indication has been considered for differentiate type. So this slide shows the indication of ESD for early gastric cancer in previous guideline in Japanese. So at first, there's only absolute indication. So after that, so we conducted the 2 multicenter clinical trials in Japan for expanding ESD indications. So JCOG 0607 was for differentiated type gastric cancer, and JCOG 1009-1010 was for undifferentiated type early gastric cancer. So based on the good results of these two clinical trials, expanded indication about differentiated type here and undifferentiated type became absolute indication, from expanded indication to absolute indication. So this is a current indication of ESD for gastric cancer. Okay. So next, assessment of curability. So important step after ESD is assessment curability here. So curability is evaluated by pathological results and decide whether additional surgery is necessary or not. Sorry, the incidence of gastric cancer is very low. However, so this slide show the algorithm after ESD based on the histological assessment for gastric cancer. So after ESD, so divided into two groups. So according to the predominant histological types, differentiated type or undifferentiated type. So among the differentiated type group, so if the region didn't meet these conditions, yeah, it judged as equals C2. Equals C2, it means the non-curative resection. So and recommended additional surgery with lymph node dissection. If the region meets these conditions and without horizontal margin positive or undetermined, it judged equal A or equal B. It means curative resection. So if horizontal margin is only the factor of non-curative resection, it judges equal C1. So it ESD, so it's only horizontal margin is positive, so ESD or additional surgery or cross observation. So we usually use cross observation, and if the local recurrence occur, we perform second ESD, but very rare. So if among the undifferentiated type adenocarcinoma, this is a condition of curative resection. So if one of them didn't met, so just it equals C2 and additional surgery is recommended. And Dr. Hatter and Professor Gotoda's group reported equal system. So this scoring system predicts risk of lymph node metastasis and cancer-specific survival in patients who did not meet the curative criteria after ESD. So if equals C2, so equal system is applied. So it's a score and the total point and the risk of lymph node metastasis. Okay. So one more important thing is if the patient refuses additional surgery after non-curative ESD, what should we explain to the patient? So we conducted a multi-center retrospective clinical trial. In this trial, among 900 patients with non-curative ESD, but refused additional surgery. During median follow-up, 64 months, recurrence was found in 27%. Surprisingly, 60% of recurrence was distant metastasis. So only 6%, 6 patients could receive salvage surgery. So these Kaplan-Meier curves show the overall survival for patients with recurrence after non-curative ESD without additional surgery. So a median survival time was only 5 months after recurrence. And if the patient could receive salvage surgery only 6 months, and the 3-year survival rate is 0% after salvage surgery. So what we have to inform the patient is salvage surgery for recurrence after non-curative ESD without additional radical surgery for EGC is difficult to perform and refuse in low survival rate. So distance metastasis may be the most common recurrence pattern in these patients. Therefore, patients who refuse additional surgery must be informed that salvage surgery after the recognition of recurrence will be very difficult. So it's only for gastric cancer. Esophageal cancer, it's a little bit different. So after the recurrence, for the esophageal cancer, there's a chance to salvage. I'm not sure about the call. Okay. So this slide summary of curability after gastric ESD. So differential type and differential type. These are ICRA A, so no need additional surgery. Okay. Sorry, gastric cancer. Talk about gastric cancer. And the next basic technique. So ESD procedure is divided into 5 parts. So marking around the region and injection and mucosal incision and submucosal dissection and remove the region. Okay. So step 1, sorry, the old video. So step 1 is marking around the region. So we usually put marking around the region about 5 millimeter outside the region. So can you see the region? Very tiny region here. And put the mark. Very old. Sorry. Mark 5 millimeter outside margin. And then circumferentially marked like this. Okay. Next step is submucosal injection. So in Japan, we usually use a hyaluronic acid solution for gastric ESD. So inject like this from distal part to proximal side. With indigo carmine and epinephrine. Small amount of epinephrine. And I will mention later, for if you use IT knife, the hole pre-cutting is necessary. Okay. Okay. So next step is mucosal incision. So circumferential mucosal cutting is performed 5 millimeter outside the marking, like this. Region and the marking and mucosal incision, like this. So I usually use the IT knife, cut 5 millimeter outside, like this. And step 4 is submucosal dissection. So, so inject submucosal layer again, and again using IT knife, cut distal part. Sorry, video is not good. Cut like this. Okay. So I will mention later. Okay. So injection, injection again, and then use IT knife from outside to inside. Dissect parallel to the muscle layer, like this. Okay. If the bleeding occur, so not so strong bleeding, so you can stop using IT knife or some other electronic devices. Yes, cutting very easy. Easy. This part may be easy. Everyone can do it. Only here remain. Cut IT knife like this. Okay. Okay. And the final step is remove the region to take it out from mouse using grasping forceps. Okay. So now there are so many kinds of ESD devices which can be commercially available. So they are divided into two groups, or IT knife series or the needle knife type. And recently, some other scissors type devices also available. So, but I worked at the Shizuoka Cancer Center from 2007 to 2021 for 40 years with Professor Ono. So he developed IT knife and ESD. So that's why I only use IT knife 2 for gastric ESD. So basic technique is different, quite different between IT knife and other devices, such as dual knife. For mucosal incision, IT knife is moved from distal side to proximal side, like this. On the other hand, dual knife is from proximal side to distal side. Okay. For submucosal dissection, IT knife is usually used from outside to inside. But dual knife, inside to outside, quite different. So sorry, today I explained ESD using IT knife. So can you see the region? So it's really difficult. So the region is located at the lesser curvature side of the angles. First step is marking. So maybe it's difficult. Can you see the border here? Okay. Here. Okay. So we usually use both white light image, chromo endoscopy, and NBI for the marking. So here is a border. So the border is here. So we put here. So we put the mark 5 millimeter outside the marking border like this. Okay. So the border is here, and the mark 5 millimeter outside the region. So region 5 millimeter outside the margin. So if the margin is unclear, preoperative diagnosis, we usually take 4-quadrant biopsies and confirmed by pathology, cancer negative, and then put the mark on the biopsy scar or quadrant and at the circumferential marking. Okay. So like this little bit big region, mark around the region. So border is here, so like this, circumferential. Okay. And we usually put the oral mark because after resection, sometimes it's difficult to identify the which side is oral side or distal side. So we put the oral mark like this and then cut. So regions here and marking here like this, like this. So like this. Okay. So next step is injection. So we will cut 5 mm outside the marking. So therefore, we inject like this. We will cut. So we inject 5 mm outside the margin. Okay, marking like this. So inject not on the mark. So 5 mm outside the marking like this. So cut 5 mm outside the marking, therefore inject 5 mm outside the marking. So inject from distal side to proximal side, like this. Inject here and here. Is it good? So injection here and here, mountain and pins and valleys. Valley. So sorry, my picture is not so good. So, but if the injection like this, so difficult to mucosal incision. So injection like this is very easy to mucosal cutting. Understand? So sorry about that. So inject additional injection in the valley like this. So there is a valley. So inject like this. So it's easy. Now it's easy to mucosal cutting. To avoid make a valley, injection will be here. This is a previous injection. So inject here is better. So inject to a slightly raised area. Understand? So it's so again for illustration. So here makes a valley, and inject here is better. Okay. Injection a slightly elevated area like this, Okay. So finish whole circumferential injection. Next step is pre-cutting. So pre-cutting is need only for IT knife. So if you need use a dual knife, it is not necessary. So as I mentioned before, IT knife cut from distal side to proximal side like this. So make a pre-cut here and then cut. Okay. So where should we put the pre-cutting? So if the region is small, only one pre-cut is enough. But the region is wide, to cut pre-cutting is easier. If the region is difficult situation, so 12 o'clock and 6 o'clock. So multiple pre-cutting is more easier. So this region, here is region and marking. So pre-cut oral side and anal side. So a little bit difficult to understand. So next step is mucosal incision. So this is a pre-cutting hole. So put tip of IT knife. This is a ceramic tip. So into the hole, pre-cutting hole like this, and then cut. However, put inside is not good. So press it against the stomach wall a little pressure, and cut like this. It's good. But this side, not you. Maybe you cannot cut. Okay. So cutting like this, you can see the blue layer, submucosal layer, like this. So after circumferential incision, like this, so marking and 5 mm outside causal incision made. Okay. So next step is deeper cutting. So cutting line is very narrow. It's not enough. So get closer and using a transparent foot and push. Here you can see the cutting line more precisely. So it's a remaining muscularis mucosa and the vessels. It's too shallow. So we need cutting a little bit more deeper. It's deeper cutting is very important. So cutting these remaining muscularis mucosa and the vessels. Here also cutting line is very narrow. So deeper cutting like this. Okay. It's a little bit shallow. However, deeper cutting, you can see some muscle layer here. And if the bleeding occur like this, so using IT knife has a short blade and long blade. So combine the covered short blade and long blade and coagulate. You can stop the bleeding like this. Okay. So before the deeper cutting, very narrow, but after deeper cutting, so get wider. It's very important. So next step is submucosal dissection. So I will mention later. We usually use a grip traction from anal side, dissect. So you can see the muscle layer, white muscle layer here. So like this, cut parallel to the dissect parallel to the muscle layer like this. So and you can see the edge of the submucosal layer. So put the IT knife long blade, put here and cut outside to inside like this. So again, basically IT knife from outside to inside, but the your knife inside to outside. Okay. So here's the edge. So put the IT knife here like this and cut like this. Okay. And this is also edge of the submucosal layer, and the muscle layer is here. So put the IT knife here and cut like this. Okay. Yes. So after resection, we take coagulate visible vessels to prevent delayed bleeding. Okay. And finally, we finish. After resection, we pin the resected specimen like that. Okay, you can see the marking, hole marking. You can see hole marking. Okay. the region here. Okay. So we don't have much time. So next, management of complications. Very short talk. So major complication associated with gastric ESD is delayed bleeding and perforation, interoperative perforation. So in large-scale Japanese ESD data, in real-world data, among 10,000 cases, so the post-operative bleeding rate was 4%, and intraoperative perforation rate is 2%. So, but very rare, delayed perforation 0.4%. So only we talk about delayed bleeding. So recently, clinically useful prediction model based on J model for bleeding after ESD for EGC was reported. So the score is here. Is the patient taking warfarin or DOAC 4 point, and total score and bleeding risk is here. If the very high risk, bleeding rate was almost 30%, very high. Okay. So how to prevent delayed bleeding? Again, so PEC. So the coagulate, tiny vessels, bleeding rate is decreasing. Or with any visible vessels, ESD ulcers should be coagulated using biopsy forceps. However, PEC and the PPI intake seem to not enough to prevent delayed bleeding for such high-risk patients. So how to prevent high-risk patient? But it's very important issue, but maybe I should talk very long time, so just one thing. So in our clinical practice, we perform closure. So we use end loop and end loop closure like this. So no time, but I will show some basic procedure. So clip and loop like this. Not much time. Sorry. But very easy. Any clip. Sorry. Close and loop and loop closure. It's very simple because closing. So in our single center retrospective trial, so the delayed bleeding for the patient with antithrombotic therapy, the delayed bleeding rate was decreasing. So in Japan now, there are so many closure techniques, but evidence is lack. So no established method. However, maybe some closure will help to prevent delayed bleeding. So maybe this approach for difficult cases next topic. So maybe so very difficult. So I will talk next time. It's better, I think. So the stomach is the esophageal is easier. Duodenum is very difficult, but the stomach is not only easy case but also very difficult case in the location. So, but in my opinion, the reason for difficult gastric ESD are location and ulcer findings. So this table shows the procedure time. So upper and middle gastric body region is most difficult location. So today, just mention a little bit. So scope selection is very important. So maybe there is a different length of the bending part, long and so for region located on cardiac or near pylorus, working space is very low. So in this part, we have to choose the endoscope with short length of this part. And shorter length of this part is better to perform ESD. And one more important thing is the maintenance of the endoscope, especially in angle, is also important. Okay? So please check the maintenance. And if the region in the lesser curvature side of gastric angles, so the longer length of bending part scope is better to cross the region like this. Okay, it's better. So we choose a scope which has longer length or bending part for region located lesser curvature side. So there are so many kinds of commercially available scope in Japan. So maybe almost same in Philippines. So please check the scope you have in your hospital and check the maintenance status also. And also you should know the difference among the scope about the location of accessory channel and water jet function. It's a different scope. And do you know multi-bending scope also available in Philippines? So multi-bending scope has a two bending section like this. So maybe you already know. So two channels, three wells. So controlling two bending section together can make it possible to change like this. Okay. And last tip, last tip is a traction method. Uh, maybe you know, so I hope everyone knows. So in Japan, there are many traction method or devices. However, for gastric ESD, it's very easy. We usually use the technique. So, do you know? Okay. So clip uh, and a dental floss, make a loop and tighten here, and then insert from the mouth, and then apply for the region like this, and just very simple, very easy. In conventional ESD, so the region located, especially in gastric curvature side, is difficult to perform ESD because subcausal layer is very here. This location we cannot use gravity. However, traction like this, it's very easy to dissect here. So traction is very useful. So we conducted a multi-center randomized control trial with conventional ESD and the dental floss ESD. So this is a result that ESD procedure time, unfortunately overall, no difference. However, greater curvature region dramatically shorten the procedure time. So I strongly recommend to use the clip traction for the region in gastric curvature side. Okay. And one more tip is change body position. Okay. So left side to right side. We can use gravity, but it's for expert, I think. So in my situation, traction method is especially clip traction is most frequently used for gastric ESD. And maybe it's an advanced course. However, the UL ulcer finding is very difficult factors for difficult situation. So like this, okay. So maybe beginner don't perform ESD for ulcer finding with ulcer finding. Very difficult because so tips. So start from places without fibrosis, and if even a little submucosal remain, dissect there. And if there is no submucosal layer, draw a virtual line and cut. And not go up, go down is very important. So like this, you can see the fibrosis, white tissue, but you can also see the blue layer. So it's a submucosal, remaining submucosal layer. So you can cut here like this. But if it's a white, only white tissue, you cannot see the blue submucosal layer. So draw a virtual line and then dissect like this. It's a very advanced course, so don't perform severe fibrosis lesion. I recommend. Very difficult. Okay. So sorry over the time. So lastly I little bit mentioned about handling of ESD specimen. It's very important. So what is goal of ESD? So complete resection is not goal. So I mentioned before. So there is the curability is very important. However, unfortunately, so there is a discrepancy about endoscopic evaluation and pathological results. So endoscopic diagnosis is not always correct, unfortunately. Therefore, pathological evaluation is necessary. Sorry, I delete some slides. So after pin the resected specimen, so after stretching, so the specimen was adequately sectioned. The key point was interval and direction. So cut interval is important. In Japanese practice, surgical resected specimen of advanced cancer is cut in deepest or largest area, but that of early stage cancer is cut more meticulously, like this. So ESD specimen should be cut not 5 millimeter, every 2 millimeter, like this. Because when cutting interval were too large, we may miss the deep invasive area or area with lymphatic involved area like this. So second point is direction. So the first incision is made to allow histological area examination of the part of the region with the minimum distance between the margin of the region and the lateral edge of the specimen. Here. It's a crosset point, so cut like this. Okay. Sorry, difficult. Like this, cut like this. So if the region is here, specimen cut like this. Cut like this, and then mapping like this. Sorry, no time. So after pathological evaluation, it's important to mapping like this. So draw a line on the section to the extent of the region presence as shown in the picture like this. So this is a summary of what should be included in the mapping. Specimen size, region size, and the distance from the margin, horizontal margin, and the deepest part where the SM invasion, and if the region mixed type, differentiate type, and differentiate type. So the histology also here, and also if the region has a ulcer finding, ulceration. So last one thing. So after mapping, we should compare the pathological result with endoscopic preoperative diagnosis. Very important. So the region here, it's a mapping like this. So compare the endoscopic image and the pathological result. So rotate like this, and then on the endoscopic image, you can see the where is the SM invasion, and this is a region. Rotate, and on the endoscopic image, and you can see the submucosal area, and the region little bit extend here. So can you see the regions here? So compared to the previous pre-ESD endoscopic image, here is here. So region is not here, but here, like this. So it's very important to learn the diagnosis, endoscopic diagnosis. Okay? So very sorry to very quickly talk so many things. So thank you very much. So many. Thank you very much.
Thank you, Professor Takizawa. Um, so Dr. Ko, Dr. Professor Takizawa, and Professor Iwatate discussed on EMR, cold snare polypectomy, and ESD. Okay. Well, to each polyp or to each lesion, it would have its own indications. As I think they briefly discussed it earlier on. Okay, so as we proceed, we'll be discussing some of the polyp types. I think there's 2 more videos. As Carlos prepares on that. Yeah, there are questions actually from the Zoom or anyone from the floor. If none from the floor, yeah, comments. From the Zoom. Okay. So this one's for Dr. Ko. Thank you for your nice presentation. I'm Dr. Ring Si from Cambodia. Oh. Have you practiced resect and discard method? Would you support this method? And how to obtain this method more accurate and decrease miscalculation in borderline?
Okay, I think for personally, I don't do discard, resect or discard because I'm not as good in diagnosing as the 3 gentlemen here. So I guess when I do personally, I do cut it off. So definitely